Good morning. Hello, Morena. I am Trina Cooper. I'm the General Manager for PADA, Perinatal Anxiety and Depression Aotearoa. And today I welcome Carolina Nad from PATH, the Post-Abortion Trauma Healing Service. And today she's talking about pregnancy issues with past termination experience. Termination is a particular and often complex type of pregnancy loss experience. As health professionals, it's worthwhile to be aware of potential impacts of a past termination on a current pregnancy experience. Understanding of possible issues and considerations around our approach can obviate some difficulties and ensure patients or clients feel well supported through a subsequent pregnancy. Carolina, I will now hand over to you.
Thank you. Thanks, Trina. I thought I might just start with a little bit of information about myself and my kind of bias and approach, I guess. I'm married. I have 3 children and 10 grandchildren, 3 of whom were perinatal losses. I have a background in nursing and am a trained counsellor with over 20 years experience in healing work with bereaved parents, including post-abortive women and men through PATHS, the Post-Abortion Trauma Healing Service, which I founded. I also share knowledge through relationships with others working in this field. I use a person-centered and holistic approach in my counselling, integrated with aspects of narrative, gestalt, psychotherapy, CBT approaches. I have a personal spirituality, which is Christian, but for me that means I particularly value non-judgment and unconditional acceptance and due care in my relationships and my work. I've researched articles around this topic through Ovid and Otago Medical Library and reading books related to this material on the internet, some of which is included in the bibliography. I'm aware that this issue can touch people and stir people in different ways, so just to be mindful that if you are stirred up from anything that's shared in this presentation, to feel free to make contact afterwards and have a conversation with myself or to talk to somebody trusted about that. I offer this talk in good faith and trust you will take from it what's helpful for you and leave the rest. Next slide. And next slide. So in 2019, there were 12,857 induced abortions in New Zealand, down from 13,282 the previous year. 51% of all abortions were for women aged in their 20s, 39% were aged over 30, and that means that 10% were under 20. Most abortions, 64%, were a woman's first abortions, but we are aware that more women are having 2 or more abortions. 64% were performed before the 10th week of pregnancy, and so abortions are also trending earlier, with the early medical abortions being more widely available. 18% of known pregnancies, live births, stillbirths, and abortions ended in abortion. Next slide. A termination of pregnancy is a part of the spectrum of pregnancy baby loss. It took a long time for the other perinatal losses to be recognised, like miscarriage and stillbirth. So it's taken even longer for abortion loss to be actually acknowledged. It is still widely a disenfranchised loss. So efforts need to be made to normalise termination loss and bring it into the spectrum of pregnancy baby loss so that the natural grief and trauma associated with the experience can be better supported. Next slide. The next 2 slides just cover the various perinatal losses and just some of the similarities and differences of miscarriage, stillbirth, induced labour, and onto neonatal death. Next slide. Multifetal pregnancy reduction and adoption. So I'm not going to talk about these slides, but they are there available for you to have a look at and to see some of the similarities and some of the differences between each of these losses. So can we go through the next slide and the slide after? Trina? Yeah. Termination may be similar to other perinatal losses in many ways. However, situations and experiences can be more complex in our experience. The pregnancy is often unplanned, unwanted, or problematic and ends in termination. A termination is an artificially induced pregnancy loss, so it's an unnatural death event, but the grief is natural. There's an element of intentionality around termination, and for some, there can also be a sense of culpability. A decision has had to be made to continue or to end the pregnancy, except in the case of ectopic pregnancy, where the termination is the expected recourse to save the woman's life. The decision for abortion or termination may be made in crisis and be associated with fear. The hormones of pregnancy may already render a woman emotional and sensitive, but if she experiences fear in the pregnancy, or if she perceives the pregnancy as a threat to herself, then it will trigger the fear response, the fight, flight, or freeze response. When this happens, there's a physiological response that happens, which causes a decreased blood flow to the cerebral cortex, that part of the brain for rational processing and processing of information, and to the frontal lobe of the brain, which decreases a person's ability to find creative solutions. The need and drive is to restore stability, and the pregnancy becomes a problem to be sorted, and she is very vulnerable to outside influences. So she's looking for the quickest, most effective solution to her problem. There's invariably a range of influences and pressures surrounding termination that may or may not be around other perinatal losses. For example, there may be political, moral, social sensitivities, context, dynamics, and dilemmas surrounding the termination. And some of these factors can constrain or influence her decision. There may be personal pressures and influences at the time relating to her background, her beliefs, her culture, relationships, past and present, and her circumstances, her hopes and her dreams. There may also be unresolved conflicts, issues around ambivalence and feelings of disempowerment that can track into the current pregnancy. Often there are perceptions and judgments by a woman herself or from other people which can shift and change over the course of the pregnancy and the termination process and beyond. Depending how she looks at the past termination now can colour her views of herself and how she relates to this pregnancy. For example, I feel I failed then as a mother. I feel unworthy and inadequate now. The maternal relationship and the level of attachment, the physical, mental, emotional, spiritual connection at the time of the termination pregnancy may seem shadowy and submerged or even denied by her. So a disconnect often happens between her head and her heart to enable her to proceed with the termination. There may be stigma, secrecy, and shame around the pregnancy and or around the termination itself. And if that's not experienced from around her, it may be experienced from within her. There may be questions around the process of informed consent at the time. Some women's experience is that of informed compliance, going along with what is regarded as best for others, or not being given full information, or having the opportunity, or being in a state of being able to process that information fully. So she may not be aware of what the implications of her decision may be at the time. This can make her more anxious now about communicating in and around the process of her pregnancy and affects her trust in the relationship with health professionals. The situation and experiences for men too all require consideration. If he was the father in the termination scenario, what was his involvement or lack of involvement in the decision, the event, and afterwards? And what did or does that mean for him and for her now? How has he dealt with or not dealt with his own experiences and reactions from the termination experience? And what have been the impacts on the relationships since that time? How is he positioned and involved in the current pregnancy? And what's that like for her? If he wasn't the father at the time, does he know about the termination? What are the implications of his knowing or not knowing on her feelings? and holding the secret in her care and management through this pregnancy? And what are his needs in the current pregnancy? So health professionals' reactions to the expectant father can either reinforce negative or positive experiences for him and for them as a couple. Next slide. Every pregnancy affects change in a woman, as does each pregnancy baby loss. Some women think that after termination, I can go back to how I was and how things were before this all happened. But this is invariably not the case. Once a woman has been pregnant, excuse me, and has had a termination, she will always be a woman that has had a pregnancy and a termination. It becomes part of the fabric of her person and her life. She can't go back or undo what is done and may possibly be affected at some level, physically, mentally, emotionally, spiritually, relationally, socially. Some women adjust quite well with their terminations and appear to have few little effects. Others may openly struggle afterwards and may lack appropriate support to work through their feelings and issues. Yet others may appear to cope initially as the psychological defense mechanisms kick in pretty quickly afterwards and may be effective for some time. But if there's sufficient stress or a trigger, negative reactions from the past termination may surface. And the current pregnancy may be one such trigger. It is usually only when the woman has a chance to share around her abortion story fully with someone safe and skilled at listening that the deeper reality and the emotions and what it has meant for her can be realized. This diagram shows continuums when looking at grief and trauma associated with the abortion. There are symptoms associated with grief like shock, denial, bargaining, sense of loss, sorrow, emotional lability, social withdrawal, loss of meaning or purpose, guilt, anger, and emptiness. And there are symptoms associated with trauma: numbness, blunted emotions, dissociation, hypervigilance, flashbacks, confusion. There may be associated substance abuse, self-harming, or eating disorders, which, if they were present before the abortion, are often noticeably worse afterwards. She may become obsessive over mistake making, controlling, difficulty making decisions, or in a victim response. So it's really helpful to notice with a woman where grief and trauma sit for her. Some women have more grief and less trauma, and others may have more trauma and less grief. So identifying the levels of each. Depression and anxiety are hallmarks of negative abortion reactions. Depression is often misclassified and not always properly linked to the abortion experience. When feelings and grief are suppressed, it's not unusual for someone to become depressed. And rarely, but on occasion, if severe, depression may slip into suicidality. So that's something to be aware of. And with anxiety, we understand that anxiety is a normal response to trauma. The world doesn't feel safe anymore. Trust feels compromised. Certainties are no longer. Fears happen at different levels, and there can be struggles with resiliency and coping. Next slide. The potential for trauma exists for all women undergoing a pregnancy loss, depending on how the event is defined by the woman, says Speckard. For a woman who perceives her pregnancy loss or termination loss as traumatic, it is so. In assessing for trauma response to a pregnancy loss, it helps to note the following most clear determinants of risk. Attachment. Attachment begins in the pregnancy, not at birth, and any interruption of the pregnancy therefore disrupts the bond. So when looking at attachment, we need to consider the strength of that attachment, the valency or the elements that combine around that attachment that were there or weren't there, the consistency of that attachment, if it remained or if it wavered. The degree of attachment in the pregnancy is very often predictive of the degree of traumatization that occurs. And the ambivalence is also significant because sometimes ambivalence reflects the level of attachment. In our experience, the greater the ambivalence at the time of the decision, the greater the attachment and risk of negative reactions after a termination. Another aspect to consider is the humanity aspect. What level of humanity did she or others attribute to the embryo, fetus, or baby at the time of the termination and now? And how did that affect her sense of connection or disconnection and her experience of trauma and loss? The degree of volition involved in the past determination decision can affect her sense of trauma. So, how responsible did she feel for that decision? How pressured or coerced did she feel? How powerless did she feel in that process? How much was that decision really her choice? And we understand that for something to be a real choice, three things have to be present: free will, full information that has been able to be processed, and an absence of pressure or coercion. And in our experience, for many women, that is not the case. Often it is a pressured, pragmatic decision in a very difficult circumstances rather than an affirmative choice in their life. For some it may be, but for many it's not. The degree of violence perceived can affect the experience of trauma from the past termination as well. For example, witnessing the delivery of a dead embryo or fetus or seeing parts thereof, having dreams or flashbacks to aspects of the experience, or concerns about whether or not the embryo or fetus felt pain during the procedure. For some, there may be a sense of violation, particularly associated with surgical terminations, which can contribute to trauma feelings as well. There may also be symbolic meanings and messages connected to the previous pregnancy and termination experience that have been incorporated into identity now. For example, I was a mother, I failed as a mother. I was pregnant, I terminated. It's my fault, I don't have a right to grieve. I don't deserve to be a mother. So some very powerful feelings can be brought up. Next slide. For each statistic, there is a story. There's a real lived experience of terminating the pregnancy, as is described in some of these experiences afterwards and with the subsequent pregnancy. One woman said, I kept expecting something bad would happen to my baby while I'm pregnant because of what I did to my first child when I had my abortion. I feel terrified I will be punished by God or the universe somehow. Another woman says, I'm now at the stage I was when I terminated my first pregnancy. It makes me wonder, what could have been. I wish things had been different, that I could have kept my baby. Another woman said, I was worried how I would react going for the scan for this pregnancy. When I had the one when I terminated, the assistant wasn't very nice to me, and I wondered when I saw the picture how I would feel. It wasn't too bad. I was sad seeing the picture, made me wonder more about what I'd lost. Another woman said, I feel scared going to the hospital to have my baby. Too many reminders of the termination, and I'm not sure I will cope. Another woman, I desperately want to have a baby, but each time I end up miscarrying. I have had 2 miscarriages, and I think it's because of my abortion. Another lady, I couldn't understand why my new baby crying would upset me so much. I would get so angry when I realized and then I realized I was angry. I was angry that my baby could do all the things my aborted baby would never do. And another woman recognized that she became an overprotective mum. I needed to make sure my children were safe at all times. I didn't protect my first baby. I had an abortion. So there can be very deep, and very complex feelings happening for her, which she may be carrying just quietly by herself until she has a chance to speak about them. So next slide. So some of the aspects to consider when dealing with a pregnant woman with a past abortion or termination. One of the key things is our own self-awareness. I think it's really important for us to know what our own position, beliefs, attitudes, and approach is, and how and if that might seep into the current relationship with our client. How comfortable am I or uncomfortable am I to be talking about abortion or to invite people to share their abortion experiences more fully? It's one thing to be able to admit it, it's another thing to be able to talk about it, and how comfortable am I to hear it? Another thing to be aware of is that I've had my own experience of perinatal loss or termination, to be mindful of my own triggers, um, and if and how that affects the way that I might respond to the woman concerned. We're very aware that a pregnant woman with a past termination is very, very sensitive to judgment often, particularly if she's had some negative impacts or is experiencing grief and trauma that hasn't been processed. It doesn't matter whether the judgment is either for or against the abortion, it is still a judgment and it has the potential to turn her in upon herself and feel like she can't talk about it or that she mustn't grieve or other things. She may find it hard to disclose her past abortion. She may talk about it as a miscarriage. And in some settings, I've heard of health professionals who, in order to protect the woman from feeling pain or shame, often, may also register the past pregnancy as a miscarriage or termination rather than a termination. And I'm kind of curious about the ethics around that. So it's really interesting that this can be quite a sensitive and quite a fraught area for people, even health professionals. Individual experiences of the previous pregnancy and termination is unique, and each person's response and adjustment after the termination is different. So not every termination experience is experienced as a traumatic loss, and for some women such events may not even be considered an issue, but for those that it is, we can't assume anything and we need to check it out and we need to be available. There's a need to acknowledge and support her grief. Grief is our response to losses and change that occur from an event, and for each person again it will be different. And one thing to be aware of is that there can be a myriad of losses. It's not necessarily just about loss of a baby or a lost pregnancy. It may also be about lost hopes and dreams, about changes in relationships, about a lost sense of self, a lost sense of self-esteem or self-worth, a loss of confidence, a loss of trust, a loss of security, a loss of identity, and a loss of role. So being able to work with the grief and identify particular losses with our client and address those losses and give her an opportunity to work those through. Many women with a past termination, as I said before, experience that head-heart disconnect. So sometimes part of this being able to share my story is about enabling that reconnect to happen. And if a reconnect happens and I grieve and acknowledging this loss in a deeper way, and depending on my view and the feelings towards the life that was lost, a woman may want to name her little one that was lost, and she may want to do some sort of memorialing. This may or may not be something that you're comfortable with, and if you're not, then it is about encouraging her to seek support from a pastor, a minister, or counsellor, or somebody to do that work with if she would like to. In any event, the encouragement here is to approach the subject. Invite some sharing of that previous termination experience. And you can do that by just asking simple questions like, what happened? How was it for you? What did you think and feel at the time? What are your thoughts and feelings now about what happened then? And is there anything you feel you need to do in relation to that experience to help you embrace and enjoy this pregnancy fully? So just being open and willing to listen. Next slide. Pregnancy after perinatal loss is characterized by guarded emotions, anxiety about this pregnancy, marking of the process of the pregnancy in terms of fetal development and safety, and individual ways of coping to meet the tasks of pregnancy by seeking out or avoiding various behaviours. Next slide. And Just keep clicking. Lovely, thanks. So this model shows the impact of perinatal loss on subsequent pregnancy. And what it shows is that the experience of pregnancy or pregnancy baby loss changes a person. So in the top half, we see how the former self is there, and then there is a pregnancy, and then there is a pregnancy loss, and then there is a changed self because of that experience. And that's quite a normal and natural process. We're also aware that for those who have a number of losses, then the picture unfolding is more complex as you get layer upon layer of loss and changes happening for her around those different losses. So whether they are terminations, miscarriages, or other perinatal losses. So then how does that affect the current pregnancy? So exploring particularly around what contributes to pregnancy anxiety. Pregnancy anxiety and a subsequent pregnancy is probably the biggest thing to deal with. So for some, there may be significant points in time, and this is usually associated with getting past that point of the termination stage or the miscarriage stage, the time when the loss occurred. So being able to get past that point in the pregnancy. There may be other things, other significant points in time as well. Birth particularly, I guess, is also hugely significant. If I can get to the birth, if I can get through the birth, then I'm going to be okay. There will be ways of coping, and these vary again from person to person. So you might want to determine social and personal contexts, supports, and needs, her resilience and coping patterns. And notice particularly any protective and defensive patterns that you might have: thought suppression, denial, anger, minimization, rationalization, avoidance, withdrawal, wishful thinking. So being able to work with those, notice those and work with those and support her. Also notice the ways that she might be using to numb pain, using substances, workaholism, sexual promiscuity, eating disorders and such like. Another concern is safe passage. Some women who have had terminations are overly worried that there may have been damage to their reproductive systems, or that for some reason they won't end up having a successful pregnancy or a successful birth experience. Particularly those with regret and guilt and shame, they might have deep worry that they might be punished somehow, that something bad is going to happen to them or their baby. So much assurance is needed, and scans and monitoring can help assuage fears that anything is amiss. In terms of social acceptance, you might wonder who is supportive of this pregnancy and how does that compare to her termination experience? What does the past termination mean for her, for the couple and the family socially? Who knew about the termination and who didn't know? Who knows and who doesn't know? Is there secrecy around the termination experience? Are there issues about disclosing the past termination? And if the health professional is being asked to hold the secret, how does that make them feel? Ruben talks about binding in, and this is about how the mother connects to the baby or the embryo or the fetus during the pregnancy. Binding in has two components. It has an objective component, which are the indicators of the baby's presence, such as fetal growth, movement, hearing the heartbeat, which makes the baby more real. And as the baby is experienced as more real, the sense of attachment, connection, and responsiveness increases for mum. For many women, through the termination experience, these components have been minimal, especially in the early medical abortions, apart from probably the ultrasound scans, which some choose to view and some choose not to view, which some see or don't see. But in the current pregnancy, these components are very much a part of the process, so monitoring the effect of this on her is really important. And then there's a subjective component. That's her own personal sense of closeness to this baby. What does she allow herself to feel? Depending on her experience before, She may not feel connected to this baby. She may feel detached and disconnected, or she may be overly attached and feel overprotective. So it can be a very confusing and anxious time for her around her sense of bonding with her baby as well. Some of the recommendations for health professionals. Next slide. We recommend a thorough intake process. When discussing reproductive history, you need to ensure that you talk about the pregnancies and ask specifically about any perinatal losses, any pregnancy baby losses, including termination specifically. Just ask openly. Some people feel comfortable to do that, others don't. Some people might feel it will trigger them, but it's important that we can actually hold that and support her and be able to acknowledge that as part of her story. Assessment and management of depression and anxiety. So there's lots of tools out there that we can use, like CAPS, looking at sleep, especially if she's not sleeping very well, looking at interest. Has she got normal interest levels in things that used to give her pleasure and the things that activities of everyday life, or has she lost interest? Guilt. How much does she take on blame? A sense of responsibility. Energy levels. Too much energy or not enough energy. Concentration, especially poor memory. And that's different from baby brain. People will often talk about having bad memory during pregnancy, but this concentration is kind of more deep and more difficult to manage. Appetite, too little or too much. And attachment in this sense is withdrawal socially, so withdrawal from people. The psychomotor aspect is being able to not being able to get out of bed or being overactive, just completely consumed with activity. It's ways of avoiding my feelings. So assessing her around depression. There are other tools like the Edinburgh Postnatal Depression Scale, the Beck and Depression Inventory, and the DASS, Depression, Anxiety and Stress Scale. So if a client demonstrates a high anxiety level, you do need to find out what particularly those anxieties are relating to and work with that. And if her depression is severe, you need to check for suicide risk. You want to elicit the significance and the meaning of the loss or losses both then and now. So just giving her time to talk about that whole experience, really, really important, and the significance of it for her. Determine the levels of conflicts and ambivalence at the time of the termination. Some of the past conflicts and ambivalence may not be resolved, and so that might be tracking into this pregnancy. Really encourage her to slow the process down to ensure she's out of crisis. And that's so she's really able to sort of, if she's thinking about particularly considering termination again, which some may if they're particularly ambivalent, you need to slow that process down and support her to make sure that she's not making a decision out of fear or based on fear. You want to help her look at levels of attachment as well, and we've talked about that already. Signs of lack of attachment may be things like lack of self-care or a lack of concern about the pregnancy, or over-attachment where she's over-anxious or over-protective. One can't assume that early stage terminations are necessarily less significant or that there was more attachment in the later stage ones. So that's fairly common that in the later stage ones people are more attached. We assume nothing. We need to find out from the client. I do have experiences of women who had early terminations for whom the attachment may not have been strong at the time, but later in the current pregnancy, those attachments have surfaced and those attachments have felt really strong for her. Identifying those potential triggers for negative emotional reactions. So sights, sounds, smells, things people said, things people didn't say, things that she needed, that can trigger memories of the termination and that can heighten anxiety now. Um, and particularly things around the medical aspects and leading up to the birth can be very triggering. So you need to be able to identify the trigger, work with her to help her to consciously remind herself that that's a trigger to do with the past experience. And she can practice putting that aside and working to stay in the present moment through mindful breathing and grounding exercises. Helping her to become aware of her triggers and practicing that disconnecting is really, really vital in the current pregnancy. Responding to any questions that the woman or the couple have about um, their perception of events that occurred during their termination as well. Um, Sometimes people may have quite strong feelings towards staff and personnel associated with their previous experience. So they might have some difficulties. And so being able to openly explore that and what they're needing this time around is really, really helpful. Um, it may also affect their ability to be assertive and ask for what they want. And we find particularly with women who have felt disempowered through the termination process, she may also feel disempowered in this current pregnancy and find it struggle to ask for her needs to be met. And so we really want to be able to encourage her and find her out what it is that she's needing and wanting and be able to support her to have a voice in this pregnancy. So this is a slide on suicide risk, and just give you a few moments to have a wee look at that. Just aware that there's lots of information there about suicidality and supporting people who may be at risk. So just invite you to research that and find more information about that for yourselves. One of the important things too is to know our limits, and so to know when to refer on, um, whether to refer to a GP, to mental health services, to supports like SANS or supports like PATHS. There are other post-abortion support services listed in PATHS and some counsellors available also listed on the website. So feel free to go to the website and have a good look. There's some good information, some good stories on the website. Yeah, so thank you very much for your interest and I wish you all well.
Great, thanks, Carolina. Really, really interesting presentation. Just to know what's happened in somebody's life, to be able to ask those questions, um, just to sort of find out their journey and what's happening for them. And we've just got a couple of questions, if you wouldn't mind answering these. Would you know what percentage of women who experience depressive symptoms after the abortion?
No, there's no real studies in New Zealand specifically around that, and there's not many that I have seen from overseas specifically around termination, loss, and depression and anxiety. So no, unfortunately not. It would be a really good kind of study to do in New Zealand. We're quite small, and it would be good as part of our follow-ups to um, to do that, or even to check with our subsequent pregnancies around the whole depression and anxiety, and somehow have some sort of reporting system, particularly if people do feel that it's been related to their terminations. But no, there isn't. Professor David Ferguson did a longitudinal study on young parents um, and who had an abortion, and he felt surprisingly that there were significant impacts, probably more than he had realised for some people. But no, I don't think those particular studies are there for us, sadly.
Right. Is there any information about medical versus surgical abortion in terms of mental health after the procedure?
Again, I'm not 100% sure. I don't believe that there is New Zealand studies available on that. In our experience, one might assume that, with surgical procedures, it's more invasive and so there's more effects. But as I said before, um, we have people coming through who have early medical abortions who can be equally as grief-stricken and traumatized once they start sharing their stories. So, yeah, it's really hard to know. Make no assumptions. Check it out.
And last question is, can women self-refer to paths?
Absolutely. Yeah, people can email in or phone in and somebody will get in touch with them. Yeah, absolutely.
Great, fantastic. Well, thanks, Caroline. I really appreciate your time today, and I know this will be of huge value to those that are supporting parents during their journey of pregnancy.
Thanks, Trina.